I think if you take that around the workout, it could be A tier because you will really prevent your blood pressure from reaching alarmingly high amounts to the point you get a tomato face or nosebleed or hemorrhoids. Hey, it's not talked about, but dude, after years of consultation, Steve, why every time I do a leg press, I get my asshole explodes.
Oh, wow.
It's not talked about, but it happens, man. It happens, especially during prep where all these guys eating chicken, brown rice, and broccoli. There's no stool lubrication. And then, of course, it pops when they go crazy, doing heavy stuff.
It's not good for you just to eat chicken and rice every meal? I'm kidding. It's a joke. It's better than eating McDonald's.
Welcome to the Anabolic Roundtable, episode 14 with Kurt Havens and Dr. Dean St. Mart. It's been, 5 weeks, 6 weeks since we sat here? Yeah, I had a birth to take care of, but I was able to cut the cord. It was a lot of fun. So my daughter was born, and I got to kind of squeeze her into existence after all the crying stopped and she was properly wiped. Interesting experience. And now I'm a dad myself, so I join you guys in the sun, basically, of being anabolic daddies. So now we should call it the Anabolic Daddy Podcast. Or the Anabolic Daddy Roundtable. So yeah, it's pretty cool. I've been doing a lot of daddy stuff, diaper changes and bottle feeding, and nothing much else. Finally getting back into the gym, so that's good. But yeah, 4 weeks, it's a total life overhaul. Very interesting. Yeah, very interesting. So any tips? Even though we already talked for 20 minutes off air.
It gets easier.
It gets easier.
It gets easier. Yeah. And just cherish it because it goes away as well. Like,
yeah, that's what I realized.
My kids are pretty grown at this point, so.
One time I picked my daughter up from the crib from like overnight. So I put her in the crib, go to bed, sleep 8 hours. I picked her up the next day and I'm like, did you just grow up like noticeably? Facial features changes, bigger, heavier. I'm like, what the hell?
Yeah,
it goes really fast. And when I compared, so I was there in the, in the area where you can kind of observe the baby right after they're born, super small, tiny, moving around a little bit. And I have videos of that. And then I compare it to, now 4 weeks later, and she's like twice the size.
Yeah, and if you do Trenbolone, 200 milligrams of acetate in the ear. With the pellets, she'll go like 157% faster. And
you don't have to feed anymore.
No, she can grow on the same amount of food. No, there's pellets that specifically say heifer on them. Just use the heifer ones. Don't use the steer.
But don't need the castrator first?
No, but it has to be in the ear, though. It's only FDA approved if it's used.
It's in the ear, right? Yeah. She didn't get my ears, though, so it's going to be different.
I don't know if they would hold all the pellets.
Yeah, my ears would. She got my wife's ears, luckily. It's hilarious.
Throwing the bottle across the room at you.
Oh, yeah, dude. She'll be talking about Mastro nonstop. Jack. We're off to a great start. Oh, man. No, actually, she was conceived on just fertility medications. Unlike Dean, right? One of your sons was produced on a small steroid cycle.
Yeah, well, the end of one, and then the other one was off. So
off, right? Yeah.
You can do both. This is why I often bring up you have to make a decision on what's most available to you. But most guys will either choose to come off and stay off, but that has its own problems. And staying on and then having the cost burden of fertility medication for months and months, because I guess the downfall of that strategy is you have to keep taking the stimulus like the FSH and whatever else to keep things elevated until you conceive. And it takes 12 to 16 weeks for sperm to fully mature. So you're sort of locked into a 12 to 16 week plan either way.
If it's not longer. It took me 1 year of trying. And my fertility, dude, if you watch my fertility video, I had like 500 million sperm pre-ejaculate. It was insane. With the highest morphology and the highest motility. But it doesn't really go far when you're 40 years old and, and the partner still has to be receptive of that. So after 1 year of natural trying, I either should have done it when we were 25 or just did like whatever sperm I produced and then I do IVF like 9 months earlier. So I didn't have to undergo that. But you never know. Like I figured, with this much semen, I could get the job done naturally. And we'll have a lot of fun intercoursing around ovulation. After 1 year, you're like, fuck, man, it's turning into a job.
Yeah. Yeah, I don't think a lot of younger guys take that into account before they start a cycle, that they might want to have kids someday.
But it's weird. The younger guys, when they're like 22, 25 years old, and their partner is the same age, you can get your partner pregnant like that. Just look at her, because they're so fertile, younger women. Oh, but it gets into a problem when you're over 35, 40 years old. And honestly, looking back now, I'm so happy that we waited and that we did IVF, because I was able to do the DNA testing. I was able to choose if we wanted to implant a boy or a girl. And even though I wanted a son really bad, we only had one son embryo and 2 girl embryos. So you have a spare.
Yeah.
In case it doesn't implant. And the implantation rate goes up, right, when you're with consecutive implantations. So the first time is like 74%, and 78, and then 82, and then 86 for a live birth. So I figured, well, if the first one doesn't implant, then we always have one boy, one girl spare. Mm-hmm. But first one stuck, because we're with the best fertility specialist here in Thailand. So he threw the kitchen sink of his knowledge at it. Heparin and all kinds of stuff, and all little vector. So it's a lot of fun discussing the protocol with him, because I do like polypharmacy. And then the first one stuck. And then right at the Mr. Olympia, I heard that my wife was pregnant. So now we're 9 months later and 4 weeks, and it finally happened. Yeah. So that means nothing else besides podcast I've been doing. I did start a cycle again, though. I was on TRT, and man, I was miserable. I was on 200 tests. I'm like, fuck, this is not enough to function, man. It's weird. Like, the older I get, the more I feel I need to run just to stay functional, it's so weird. I was on 200 tests, like 100 propionate Monday and Friday. And I was like, man, this is not cutting it, dude. Maybe that's, the postpartum depression. I don't know.
You weren't getting dips there?
No, not really.
Okay.
No, I mean, the fluctuations, they're noticeable. Okay, Thursday, you're like a little bit like, fucking nothing crazy. But on Wednesday or Saturday, right after my shot, like, propionate peaks pretty fast.
Yeah.
I was also not feeling it. I was like, I don't want to go to the gym.
Why propionate?
That's what I had.
Okay.
So I vouched myself this year not to buy any gear. So if somebody wants to give me gear, sure. So I have a whole cabinet full with stuff that's like leftover, because when Aaron left to the United States, obviously he couldn't bring his gear, so he gave me whatever he had, and it was all pre-contest stuff. So I ran first through my own gear, and now I'm running through Aaron's gear, and then once that runs out, then I'll ask one of the affiliates to send me some gear again. But there's just so much there. Please don't come to my house. I'm not trying to incriminate myself. I'm trying to dispose of it as humane as possible. So the propionate is finished, and now I'm on 300 tests, 300 Deca, and 150 mint. And then I might continue the mint.
Deca
so I'm doing
and mint together.
Yeah, but I had gyno surgery.
No, but how do you feel?
I feel great.
Okay.
Yeah, that's why I went on the stack, because I did it last year for an off season where I got too chunky, and I'm still dealing with that. Still dealing with the chunk now, to grow the gyno and get the most obese looking gynecomastia tissue, which was fully removed and now looks beautiful. But I felt really good on that cycle. So I was like, you know what, I'm going to do it again, make myself look extra watery, and then start cutting. So I'm more motivated. Because now I look like a bag of smashed assholes with this much Deca and this much mint. And I'm controlling my estradiol, obviously, but still it's like two progestogenic 19 Norths that make you look pretty watery. So my lower back is literally like, I don't know, it looks like a camel, 2 camels, both sides. And I'm like, fuck this. Like my lats, it attaches to my lower glute, basically. It's at one pillar. It's not nice. So, but at least I'm more motivated to get in shape now. And I noticed the last time I was doing this follistatin experiment in YK11, everything started getting a little bit dry and squeaky. So I just want to not worry about my joints and connective tissue for a while I try to get lean. And then fingers crossed I can get lean, and then I'll pull the Deca and the mint, replace that for Primo and a little bit of Mastrone. And then, the magic will happen, fingers crossed. So... yeah, I'm just trying to torture myself right now, but I feel very energetic and very good, and I'm strong as shit already. So, yeah, that's why I'm on the off-season.
What do you weigh now?
107, 108.
Okay.
Yeah, no GH. I don't want to be lethargic.
That stayed with you? That should go away.
Yeah, it goes away, of course. But if I add the GH back in now,
it'll come back.
It's going to be a vial at a time, right? I have like 5 kits laying around of generics, so it's not going to finish itself. And Dean, what was the hormone replacement therapy dose for parents? 4 IUs?
4 was what we settled on. Times 4 in your case.
So if I do 4, the GH will last until like the end of next year. So I could do like 10 IUs generics. And generics, you just use a vial at a time. But then I'm really sleepy. And I was really lethargic after the follistatin experiment. And then the Ngenla crept up to me. And I was running some cagrilintide that made me very sleepy. So I'm like, you know what, get me on the Dr. Dean stack and some off-season drugs, and then I can function. So now I'm kicking ass and chewing bubble gum again. But I had like a 4-week dip of like, I don't know what to do. And I don't feel like a bodybuilder and I look like a fucking dad bod. But it's picking back up again. Yeah. It's pretty bad, man. We stayed in the hospital for like 4 days or something after my wife's birth. Yeah, because she had the cesarean. So
yeah,
stayed there for, she had to stay for observation. And here they're really, like my sister gave birth 2 weeks before I did, and they checked the baby and sent her home. You know, that's healthcare in the Europe. And here they're really, well, that's why we went with a private hospital. Here they're really attentive. So they really took good care of us. But then you're staying in the hospital room for 4 days straight, watching TV.
When you're paying for it, that's why they'll keep you there. If insurance is paying for it, they're not going to keep you there.
Well, we had insurance.
Oh, I'm just saying in the U.S.
Yeah.
No.
So, but the insurance, I think the entire hospital bill was $15,000 for cesarean and aftercare and private room. And
that was after insurance or before insurance?
The insurance paid for the whole thing.
Oh, good. Okay.
Yeah. But we got insurance right before the implantation.
Nice.
So we need hospital insurance. Okay, we got the hospital insurance, and now we can start implanting the embryos. We had that grace period that you have to wait. Yeah, so that all went well. But we're here to talk about drugs, not about parenthood. I wanted to start a tier list again, but for ancillaries, where we can talk about blood pressure management tier list, a kidney health management tier list, lipid management tier list, liver health management tier list. And I'm sure we can come up with a lot of other tier lists, and I'm sure you guys will let us know in the comment section. Do a XYZ management tier list, an acne management tier list, or a hair loss management tier list, or gynecomastia management tier list, right? So we can keep going until the sun turns off, a couple billion years from now. But I think for this podcast, since we always ramble and go scientific, let's try to do the blood pressure management and kidney health management tier list, because that's kind of related. Kidney health, blood pressure kind of goes hand in hand, and then lipids and liver kind of go hand in hand. And then the acne and the hair loss, so that's probably estrogen related. So that kind of goes hand in hand, and then we'll figure out from what the audience wants. So regarding blood pressure management, let's just start with electrolytes. The overlooked method to control your blood pressure. And I know Dean is really on the edge of his seat to talk about magnesium. So
well, I think we're going to be shifting focus with blood pressure to potassium. Me and Kurt have covered this.
True. Yeah. Take it away, man.
Nearly 2 years ago, around the importance of potassium and blood pressure regulation. So I guess what you've touched on, electrolytes, is hydration. And when we say the word hydration, people are like, yeah, but I drink 3 to 4 liters of fluid per day, or I drink 2 gallons of water per day, I'm hydrated. You're probably pissing out all your electrolytes with that much fluid if you're not taking the electrolytes with the water. So the water's neutrally charged, so it needs an electrical charge to be pushed in and out of cells. And that's where the ions, sodium, potassium, calcium, chloride even to an extent, phosphate.
Yeah, phosphate.
They all help with pushing fluid in and out of certain cells or different transporters. And when we look at what regulates our blood volume, as in the volume of fluid in our blood, that's where sodium becomes important. So sodium will retain volume of fluid in your blood, which is where blood pressure will increase because you've increased the volume of your blood with more water or more pressure required to push that around. And potassium works in the opposite fashion, that potassium pushes fluid into your cells through the potassium pump. So when we're looking at someone who is like pre-contest, getting ready to get on stage, and all of a sudden they're flat, their muscles appear flat, they're not able to get a pump, they've done two things there. They've both gotten rid of sodium out of their bloodstream, so now their blood volume has dropped, which then in a certain instance will put the brakes on diuresis, so you actually start to retain fluid, or you look much softer. And you'll have also lost some extent of potassium inside your cells, which deflates the appearance of the muscle. So if we're looking at managing blood pressure, the simplest task that we should be aiming for is a 2:1 ratio to start between sodium and potassium intake. The sort of golden numbers I often suggest is 4,700 milligrams of potassium, which is the RDA for potassium, and then somewhere around 2,000 milligrams of sodium. In most contest bodybuilders, it's actually way more sodium. They're salting every meal. They think like salt is key for a pump, which is true. But
I think people misunderstand the pump. So the pump is outside of the muscle cell, right? The sodium by osmosis pulls the fluid out, and it's around the cell. But where does muscle protein synthesis occur? It occurs in the cell. So the pump doesn't contribute to growth because it's not occurring in the muscle cell. You're just getting a visual look from it, right? And sodium in serum is very tightly controlled in the human body. It doesn't matter if you take in 1,000 milligrams or 10,000 milligrams. Within a day, it regulates, and then it's the same. So it's when these guys take this huge excess amount, they're not necessarily achieving anything. All they're doing is causing more excretion, so the body will balance, right? You see the same level on blood all the time, otherwise you'd be dead.
Yeah, and it's not like you're just excreting sodium.
No, you're then excreting everything. But
you're excreting the rest also,
excess
because
amount of
it's
salt
not
doesn't make any sense.
No.
You know, like Dean said, 2,000 milligrams is plenty.
I think it does make a little bit of sense to increase your sodium intake if you train in the gym without air conditioning. So me, for example, I sweat buckets. So I drink about 3 liters of fluid during the session, ice cold water, because I need to cool my core temperature down. And I sweat profusely this entire session. Like
with your carbohydrates lower too, you're going to excrete more.
Yeah, exactly.
You know, your diet dictates that versus someone on a high carb diet doesn't need as much sodium.
So that's true, right? Probably I excrete more sodium also through urine because I have a carbohydrate deficient diet, basically. And then the sweating really depletes my electrolyte level. So my sodium intake is a little bit on the high side. But, you know, I wouldn't recommend people to do that in a country where they don't sweat profusely.
Well, and even, and Dean, correct me if I'm wrong, even in athletes, though, that are used to training in that environment, though, the kidneys get very used to still maintaining it. So your sodium loss is probably not as great as it was initially, right? So when you first went to Thailand and trained in that environment, you were losing a lot of sodium. And then after a period of time, relatively quickly, your body got used to that.
Yeah.
Right? So it's going to retain, you know, just to keep the balance again, because it's all about keeping that balance in the serum in a constant range all the time.
And then that being said, still my potassium-to-sodium intake is 2:1, like Dean said. So if I have 5 grams of sodium, it's 10,000 milligrams of potassium per day.
Yep.
And it's fairly easy to maintain that ratio with salt substitutes. Like guys often ask, how do you do that? Well, you find a potassium iodide or potassium chloride based salt. And normally these are in a 2:1 ratio. So you have like 450 milligrams of potassium and like 200 milligrams of sodium. And so as you increase your salt intake from that sort of perspective, you maintain that ratio. So if you weren't even to account for any of the salt, sodium, potassium in food, we have a product in the UK called low salt, or there's other different brands of it. 11 grams of that works out pretty much to 4,500 or 4,600 milligrams potassium, roughly 2,200 milligrams sodium. So even if you were on a contest prep diet, or even in general, and you're worried about maintaining this balance, just weigh out 11 grams of low salt and distribute it across all your meals. But like that, like what you're covering about training, then you have to think about what you're losing with sweat. You have to think about the rate of replenishment as well. So if you've lost a large chunk, like Kurt said, you've got homeostatic balance with aldosterone, an antidiuretic hormone, to try and retain sodium in your body. And obviously, we've done the pre-contest talk before. This is like the basics behind sodium loading that used to be done years ago. You just ramp sodium higher and higher and higher. And then one day out from the show, you literally done no sodium in hopes of you've pushed your aldosterone balance so far that antidiuretic hormone kicks in and you just flush all that subcellular fluid or subcutaneous fluid out of the body to have a drier appearance, which we know doesn't really work in practice.
No. I just have guys measure, starting 8 weeks out, just tell me how much sodium they consume in a day and how much potassium they consume in a day and how much water. And I just try to keep it constant, right? Because it's the variations that screw up the look, right? Because then I can also add a little more, take a little more away if I need to change it. But if you don't know, a guy he's in peak week and he has no idea how much sodium he's consuming or potassium, it's really difficult to, right? You can kind of guess by the look and what they feel, but that's a really tough game to play.
Yeah, and it's hard when they start switching their meal plans around. So you have a couple of days of depletion and then a couple of days of loading. So there's a caloric difference there. And then you go from, let's say, 6 meals to 10 smaller meals. So how are you going to salt that? That's why I always put the electrolyte balance in my diet sheets. So it's easy to keep track. And then you remove the column for vitamin C and vitamin D. That's kind of irrelevant in the peak week. But I feel it's very important because like vegetables and stuff and most animal protein has a good amount of potassium in it. Mm-hmm. And not so much sodium. And then depending on which vegetables or condiments you use, like if you add a pickle to each meal, you're going to increase your sodium intake. If you add soy sauce to each meal, you're going to increase your sodium intake. And these simple little things, it's just very hard to keep track of if you don't put that in a diet sheet with the electrolytes listed, or at least measure everything consistently, where you use like a cocaine scooper to measure yourself. But
very few guys measure accurately, right? And I found that. So outside of a handful of guys that are really accurate with what they do, at the end I give guys exactly what I want them doing every day, specifically, because people assume, like even with macros, they're just off, right? You can tell, and that it doesn't even line up at all.
I often laugh at when it's like measured in grinds. I've done 4 or 6 grinds of salt on my meals. And I'm probably going to trigger a lot of people in the comments, but if you're measuring your salt intake through grinds of salt, have you actually ever weighed out what 6 grinds of salt is? 1, 2, 3, 4. It's like not even half a gram of salt. Yeah. So...
Right, and it's the same with sprinkling and counting the seconds. Yeah, I did 2 seconds of sprinkles. Or with the sugar, the British sugar thing, where you go 1, right? And then as the sugar comes down, it's less, so you start pouring more. Right? That old school crystal sugar measuring device. And I asked my mom to do that once time. I said, how many times do you do that in your cup of coffee per day? So she started doing that, and she's just eating like 100 grams of sugar over the day. So, well, now you know when you're not in shape.
So I guess with blood pressure, the very first thing is electrolyte balance. That's the easiest and simplest thing to start with is your electrolyte. Forget about angiotensin, forget about ARBs or this, that, and the other. Get your hydration proper, and then from there, the second ancillary, if you want to tier it, is cardio. Just cardio fall into.
Wait, you don't just take a bunch of drugs instead of watching while you're eating and exercising?
We're not going to sit in the sauna to bring the sodium down, and and then do the ice bath for the
just go back and forth,
adrenaline dump, so you don't get the vasoconstriction. Cardio, really? Haven't we been saying this for the last 14 episodes?
It was at one point called fitness. I don't know where that went, but okay.
So simple tips aside, I guess, electrolytes, cardio, and then the other one, before you even go near drugs that would improve like vasodilation and improve nitric oxide content of your blood, is nasal breathing. So pay attention to how you're breathing, because your biggest reservoir of endothelial nitric oxide synthase, eNOS, is in your nose.
Oh, wow, okay.
And so,
I thought it was in your mouth.
No, if you breathe through your mouth, you're actually limiting your eNOS. So that's where breathing through your nose, everyone wearing nose strips and everything, as you breathe in through your nose, the warm air that's coming in through your nose activates the enos enzyme, or so they believe. And so then that leads to higher levels of nitric oxide being produced in your bloodstream. So nasal breathing, if you're doing cardio, nasal breathing up to a point where then you're at an exertion level that you have to mouth breathe, but nasal breathing combined with cardio is a surefire way to lower blood pressure from nitric oxide production. So those simple things, I guess then you get into more fancy ancillaries, whether we start taking
well, we gotta tier them first. So we got cardio. I don't skip ahead too much.
We're doing S to F again?
Yeah, we're doing S to F. So I think we can all agree that electrolyte management, including the magnesium intake and calcium-rich foods and stuff, and cardio, that's just certified S tier. You just no excuses. Off-season, cruising, blasting your socks off, just watching this podcast and not really following bodybuilding. Yeah, you'll be surprised. I watch this podcast. I love the Anabolic Roundtable. And there's no anabolism in sight, but they love the pharmacology aspect. So even those guys that are just here for research purposes, cardio and electrolyte intake, stable. Please. Please, because I can't go through all these emails. You know, I started my anadrol cycle and my blood pressure's through the roof. And I ask, what's the diet and the cardio look like? Diet? Cardio? I want to get big. So, okay. All right.
Start the basics.
Yeah, start the basics. So S tier for both. I want to briefly discuss magnesium and calcium intake, since it's part of the full Monty of electrolytes. So I supplement with about 200 milligrams magnesium bisglycinate with every meal, 5 times per day, so that's 1,000. And then based on my dietary magnesium intake, it's also about 1,000 from the animal meat sources and the nuts and seeds and the vegetables that I get. How bioavailable is all of that? You don't really know, but it's about 1,000 milligrams magnesium. And then I get about 1,500 milligrams calcium just from food. There is some calcium in the supplements that I take, like vitamin C, ester C. It's a little bit more highly bioavailable vitamin C formula with bioflavonoids and some calcium bound in there. And then apple cider vinegar has a little bit of vitamin C, and the multivitamin has some vitamin C. I take all of those with meals because I don't want that calcium to dump into my bloodstream, potentially, sticking plaque and stuff. Don't worry, I take my vitamin D and vitamin K and all that stuff, so it goes into bones. But I notice that if I have a very stable intake of all of these electrolytes, supplement with a little bit of magnesium, again, the sodium, potassium, that's mostly for flavor, right? And keeping everything stable, that my blood pressure is solid up until I start pushing into the gram ranges. Yeah. And then when I go over a gram of steroids, I do need a little bit of blood pressure management. But that's mostly because my blood pressure shoots up during the workout, not when I wake up. When I wake up, I'm 165 over 125, regardless of how much shit I run. It's just mostly to protect my kidneys during the workout because, a lot of violence occurs when you're over a gram. It's not a pretty sight, When you go to the gym, you're over a gram of steroids, then a lot of heavy weight and a lot of grunting and a lot of pushing to failure and beyond. And that just increases your blood pressure. There's studies that show that, where they put like one of those measurements into, one of the arteries here, and they mention the intravenous blood pressure during strenuous sets, and it's just undetectably high. It's like 240. It's insane. So, and that's where you have temporary pressure in your kidneys, which we're trying to avoid. So that's really the only reason why I run blood pressure medications. But with cardio and electrolytes and stable hydration, I can manage my blood pressure at rest just fine. Just fine. So S tier for those two. What's oh yeah, you said the intranasal breathing. It's new to me, but I'm not a mouth breather, so I guess my enos production is pretty okay. Where would you rank that compared to cardio and electrolyte intake, hydration?
Nose breathing, I probably put it A, because you should be nose breathing in your sleep. So if you are waking up with a big dry mouth and you're snoring, nasal breathing is very important during sleep for reducing your blood pressure in your sleep.
Would you say then on that topic, if there's several masks, right, for CPAP machines. I mean, I think 50% of our audience has a CPAP or needs a CPAP. I'm assuming 50% of you guys are big as fuck. So you have the full face mask and the nasal pillows. It's like this, and then the little nasal, little nasal mask. So that's the one I use. So based on that, I would say that the nasal mask is superior over the full face mask because it allows you to nose breathe and nothing else. As it pushes through your nose.
Until you open your mouth. So normally if you do use a nasal pillow for CPAP, you're probably better off doing like the micropore mouth taping. So you're actually closing the system. Because what will happen is when you snore, when you release tension on your jaw and you open your mouth, the CPAP pressure is designed to force your mouth closed again. One side, that can be like detected as an apnea on your CPAP. But the other thing is, if you're sleeping beside your partner and you open your mouth and all you hear is the air escaping out of your mouth, you're going to get a slap. So to keep the system closed, that's why you don't hear these sort of hisses with full face mask, because the pressure is basically, if you open your mouth is closed straight away from the full face mask.
Right. So in both cases, it's probably best to tape your mouth closed anyway.
Just the way when you see crazy people do all these sort of things with micropore taping, all you need is like a small little square strip, put it between your two lips, and that's it. And that's enough. What you're trying to do is psychologically train your mouth position to keep your mouth closed and keep your tongue against the roof of your mouth.
Right.
That can have absolute wonders to your blood pressure, like snoring, hidden hypoxia. It can ruin your blood pressure. Like when we think about it, when we're at sleep or like the early parts of the night, the process is called dipping. Your blood pressure should be its absolute lowest during the night because your cortisol level is extremely low. And that's why then when you do your blood pressure in the morning time upon wake, your blood pressure is supposed to be its highest value upon wake. So what we can sort of determine from this is who is at risk of cardiovascular disease through a process called reverse dipping. So if your blood pressure in the morning, say, is like perfect 120/80, and then your evening time blood pressure is 135/90, you've got this reverse dipping happening. It's signaling that something's not right in terms of the body's ability to manage blood pressure. It could be that you've trained late in the evening time, like you've trained close to bed. That can be a confounding factor. But normally, if we've got 2 restful periods, either when we wake up in the morning time, do your blood pressure then, 2 hours before bed, wind down, blood pressure before sleep, it should actually be lower than the morning reading.
Yeah, I think the only time when it can really be higher is post-workout.
So
of, the adrenaline and stuff.
I've got one of those high-low bands, or what was the name of it? They were called some Acne, I think was the company's name, but they've renamed themselves Hilo, which is a wrist strap blood pressure monitor that works off a laser diode. You calibrate it with an arm cuff, so it is calibrated correctly with an arm cuff measurement, and then it takes your blood pressure pretty much every 10 minutes when you're sitting at rest.
Okay.
And so you get this huge insight into your blood pressure of how it changes across a 24-hour period. I put it on my story loads of times. Like, I suffer with low blood pressure, and that's genetically from my mother. So like, I put it up on my story before. My blood pressure can be like 100/59 over 60, and guys like, oh, how'd you get your blood pressure so low? It's like, well, it's just genetics.
Yeah.
So and the reason why I put that content out is if I was to start throwing an ARB in or whatever else we're going to discuss about here, I'd probably end up hitting the deck with like hypotension, or I'd faint and smash my head. That you have to be very clued into your blood pressure and whether you need to manage it or not. And quite often I actually enjoyed off-season or pre-contest because I actually took my blood pressure from a low position to a relatively normal place where I didn't have the symptoms of like heavy body, heavy head, lethargy. So something like that, if you're concerned about your blood pressure, probably for the big guys that are listening to this, I think the cuff only goes up to about 17.5 inches. I think there is plans for them to bring out like an extra large cuff for the calibration. No,
you
but
mean
this
that's
company,
this particular one? Yeah,
this
For fat
company,
people, you can.
I think they were going to
Hormones.
bring out like an XL cuff so that they then had the calibrated data for people to wear the band if they are like a big bodybuilder. I'm fortunate or unfortunate enough that my arm size is just under 17 and a half, so I just about fit into that
Gotta
arm
up that
cuff.
trend. Up the trend.
So, I mean, I can utilize that type of equipment to keep an eye on my blood pressure, but this reverse dipping, very important to manage, and the electrolytes and everything else we've discussed plays a big role.
Yeah.
I guess the next part then is probably dietary supplements.
Yes.
Start with
So
the low-hanging fruit as opposed to going straight to the pharmaceuticals.
Like berberine,
Yeah,
you're talking
yeah.
like berberine?
yeah,
More
berberine
so-
has that's mostly for lipids and blood glucose management. But the funny thing about these Ayurvedic herbs is that they're super studied, right? In India, mostly Indian studies, and then there you can fix every ailment. And usually those studies are funded by Himalaya or whatever company produces those Ayurvedic herbs. Carditone though does have some merit. I know Dante Trudel was always talking about Carditone because a lot of guys couldn't get their blood pressure medication. So that's the one I
So-
kind of want to rank. It's just a herbal formula.
So Carditone basically actually has an active pharmaceutical ingredient, if you want to call it that.
Oh, really?
So
Okay.
I guess the segue here is natural herbs still have medications inside them. Like this
Yeah,
is...
red yeast rice, for example.
Yeah, like when we're looking at herbs, they can be just as potent or as dangerous as pharmaceutical medicines. At least with a pharmaceutical medicine, you're taking potentially one ingredient and it creates one metabolite as one mechanism of action, one mechanism of excretion or whatever, and it's very targeted. When you take herbs, the standardization of the herb is important, the active components, the synergistic effect of the herbs also. So we have this synergistic effect where herb A and herb B can complement one another, or they can create more dysfunction. So there is this entourage effect. I always forget that word, entourage. And you see this with like cannabis, the entourage effect between isolate and the full spectrum plant. The full spectrum plant has the entourage effect of all the things inside it, basically. So if we're looking at Carditone, the active ingredient in it is called reserpine. It is actually a norepinephrine blocker or norepinephrine receptor blocker.
There you go.
And how it lowers your blood pressure is by lowering norepinephrine levels within the brain. So now we reduce the stress hormone on the brain, which causes vasoconstriction. And we have this knock-on cascade effect where we reduce blood pressure from an adrenaline perspective. But unless we know that the blood pressure is being driven from a cortisol or an adrenaline conversion perspective, it's going to be fairly useless for lowering your blood pressure.
Okay.
Now, in saying that, most guys have a lot of stored noradrenaline. So in the scheme of it, dopamine converts to adrenaline or epinephrine, and epinephrine converts to norepinephrine. And norepinephrine has vasoconstrictive effects. So taking reserpine, you're blocking that off the brain so the blood vessels can actually relax again. And you do see, anecdotally, anywhere from 8 to 12 point reduction in systolic from this cortisol inhibition. So it is a useful strategy, but it's very case specific. So if you don't have cortisol issues driving your blood pressure, reserpine isn't going to do too much.
Doesn't it also raise serum potassium as well?
Yeah, there's a good amount of potassium, Carditone.
Which is going to help that as well.
Yeah, it will. I've never seen that. All I've ever looked at is the active ingredient, which is reserpine. But it is useful. It's available. Not like anything can't be available, but it's available in a legal fashion as a supplement. It's like a try it and see approach. Like if someone has blood pressure of like 145/90, given the context of what they're doing. Maybe if they have a very stressful life or stressful job or anything like that, you might lean towards reserpine first. But most people are going to go the other way and block angiotensin first, see what happens. And if that doesn't create a drop in blood pressure, well, then you know you're going back to adrenaline being the problem. So normally I would go at angiotensin first, and then the scheme of it go towards noradrenaline as another way of getting it down if the ARB or the ACE inhibitor didn't work.
Okay.
But case specific, if it is a cortisol issue, then I would say from a tiered perspective, I'd place it quite high as a readily available supplement.
But in that case, Emodin, which actually inhibits cortisol production, might be a more suitable solution to, at least to the point you address the root cause of why your cortisol is chronically elevated.
Yeah, I guess with Emodin being a cortisone blocker, so you're blocking the conversion of stored cortisone to cortisol, that you're then upsetting, like Kurt said, there's always a dynamic balance between having enough stored cortisone and converting to cortisol for like circadian rhythm, daily energy spikes, adrenaline output, blood glucose management. That you see sometimes anecdotally that Emodin just blunts someone's cortisone or cortisol too low, and then that of itself has problems
Can't get out of
the
bed.
body.
They
they don't have issues getting out of bed, and then they're finding that during the day that their energy is dropping off because they don't have this lift in adrenaline. They're useful. Like I said, this is where it gets interesting that we see these natural things and they do have side effects themselves. So
yeah. And keep in mind, some of the formulas of Carditone also has Rowolfina serpentina, which contains alpha-yohimbine, also known as the stereoisomer rowolsine, which is an alpha blocker. And that by itself in low amounts can actually improve blood pressure, but in higher amounts.
Not in higher amounts, yeah.
And Dean has experience.
yeah,
And you OD'd on yohimbine one time, right?
not a fun experience.
No, I can imagine. So that can increase your blood pressure. So there, with some of these things, there also seems to be a dose-dependent response. If you have one capsule of Carditone is good, 2 is better, so I'm going to take 4, and then you might, be wired and cold sweats and elevated blood pressure.
That's a clear example of it's like case specific from a mechanism perspective, that if one capsule after a week isn't doing anything to your blood pressure, it's more than likely not norepinephrine induced. So either continue taking it because you bought it, or
finish the bottle and don't buy more.
or figure out what's the next root cause to your blood pressure issue. But I've seen it work. I've seen guys who you see pre-stage 1 hypertension, and it's enough to bring them down.
So could Carditone then be a good solution for training-induced hypertension, where you have chronic elevated cortisol levels because you're basically overtrained, or you have chronically elevated adrenaline levels because you train, doc rep training, or you have to beat the logbook and you kind of psych yourself out, increasing your blood pressure that way. You look at the logbook, 12 plates for 12 reps, and it's 8 a.m. and your workout is at 2. You already give yourself anxiety and high blood pressure just looking at the logbook. I mean, we've all been there. It's just for the next 6 hours, fuck me, this is going to suck. I think in that case, Carditone really helps because you kind of do it to yourself. And there is training-induced hypertension, from electrolyte depletion and this adrenaline that you kind of, raise by yourself.
Because if it's cortisone, growth hormone will prevent the conversion of cortisone to cortisol as well.
That's true. So that's where the replacement dose of 4 IUs before bed comes into play.
Yep.
So would a replacement dose of 4 IUs growth hormone before bed be more suitable? Water retention included, right? We have to keep this in mind.
And there's other benefits from the growth hormone.
Yes.
Right? But I mean, when I take
few more.
prednisone, I need to take a much larger dose than someone not on growth hormone. Because I can't convert it.
Right. So if we're going with the tier list, then technically we'd have to put growth hormone over Carditone as a blood pressure management method if it has to do with cortisol.
If it has to do with cortisol, the initial fluid retention, that's going to flip
Yeah.
the opposite way for blood pressure, but that should go away.
But if your potassium intake is high, which S tier stuff you should do first, where are we going to put Carditone? It does work. I've seen it lower blood pressure, but it's not like, well, it's magic. It's not F.
B or C.
No. Yeah, I'd agree with Kurt. It's either B or C. I mean, it's very, like I said, case specific. Whereas if we took probably the next two, like dietary supplements to tier, it would be Hawthorne berry, which is very rich in arginine, which converts to citrulline, or beetroot extract. And
That
this
is a
is
very good way. And it also helps with the pumps tremendously.
And that is where we see this synergy come from. Now, if we look at some of the studies on hawthorne berry by itself and beetroot extract by itself, they lower systolic blood pressure maybe by 3 or 4 points. We put the two of them together and we take advantage of the improvement in citrulline to nitric oxide, and then we have a direct source of nitrates from the beetroot itself. We see a reduction in blood pressure anywhere from like 6 to 8 points. So, and that was the premise behind the kidney and blood pressure stack that I formulated years ago. Was this entourage effect when you combine standardized hawthorne with standardized beetroot extract, you're improving this availability of nitric oxide in the blood. So if we're looking at like a more global approach, again, we're coming back to dietary nutrition. There's still, someone could incorporate beetroot or beet juice or pomegranate juice, these specific foods that give this benefit. And this is where obviously a supplement is supplementing this food into your nutrition.
Can I add another one to the list that's not on there that actually has been studied? Flaxseed oil has a pretty profound effect on that as well. On a side note, that's why people need to be careful when they use the word seed oil, right? And they group them as this bad thing, because seed oil is not actually a group of anything. It's a vague term, right? So there are seed oils that are clearly not good for you.
Those are people that are hand puppets for the carnivore.
Yeah, and
they got Paul Saladino's hand in their ass.
Yeah, and so two of the fats in flaxseed oil are the only two essential fatty acids that are needed in the human diet, right? That are then converted to EPA. Right, we just consider fish oil to be an essential fatty acid, but technically we produce it. Right, we just don't produce enough of it, so we take fish oil as well. Right. But flaxseed oil is something I've used since the '90s, and it's partially why my blood pressure is always low, like Dean's, and it's partially why they miss my lack of kidney function, because they would expect you to have high blood pressure.
Right.
So no doctor ever picked up on this until I did organ scans to find this, because I don't have any of the symptoms. I'm not diabetic. I'm not overweight. I don't have high blood pressure. And so all the classic symptoms.
But you treat yourself right. And that even with one kidney, you can.
Yeah. Drinking was the only thing I did that made the function go down the toilet. But
it's okay. You've all been young.
Yeah. But but flaxseed oil, I think, is something people should consider adding to the diet.
What volumes are we talking about?
I don't think, I mean, you could use a tablespoon a day. I don't think it has to be anything. Right, that supplies almost 8,000 milligrams of those fatty acids in a tablespoon. Right. I mean, realistically, how much fat do you need in your diet, especially if you're enhanced?
Right. And before we start complaining about lignans inhibiting the androgen receptors, the lignans, well, they're only found in full flax with the fiber.
Yeah, well, I'm talking about the oil, not the
no, exactly. So that's why I want to emphasize
how much they block the androgen receptor if you're taking a
Oh man, I talked about eating a bag of licorice, and people were like, "Yeah, but Steve, you said that licorice root extract is an anti-androgen, so you empower people to hold it against you." And it's the same with flax seeds. I had some flaxseed meal to my my meals, and it makes it taste like nice and rich. Yeah, but Steve, it has lignans, and those inhibit the androgen receptors.
Yeah. So you got plenty. I wouldn't worry about it.
Yeah, I got plenty of androgen receptors. Yeah, and I think the DECA is a little bit higher binding affinity anyway
than flaxseed oil. I would say so.
Yeah, no, but there's no lignans in flaxseed oil.
I'm sorry, then flaxseed.
Yeah, just flax. So before people start complaining, so don't worry about it. And 1 tablespoon, if it improves your blood pressure, then all the more power to use less medications.
Yeah, and I would always rather go that route with at least my clients.
Yeah,
the nutritional stuff versus throw them on drugs.
And I think that they show the same, like with a tablespoon of extra virgin olive oil or macadamia nut oil, that it has some blood pressure lowering effects.
Yeah, I guess it's antioxidant based.
Yeah.
When you're looking at what drives blood pressure and what increases oxidative stress is one thing that will contribute to vasoconstriction.
And the arterial shearing is less because of the healthy fats. So the quality of the endothelium is better. And then instead of, there's a little bit of resistance inside the bloodstream, the blood can now flow, and thus blood pressure is also improved. And all these little things contribute. And that's why I always laugh when people go straight to, Telmisartan, because there's so many things you can explore that actually not only improve your blood pressure, but your overall quality of life.
Yeah. Well, where did the Telmisartan thing come from? I mean, he looks very healthy. That gentleman looks very healthy to me.
Yeah, and he has stock in Boehringer, what is it called? Engelsheim, whatever.
It's like he has stock in Dunkin' Donuts.
Yeah. Hey, man, everybody needs a gimmick, so...
I mean, even when we look at the recommendations for blood pressure management, and I can send it to you after this, and we can put it up on the screen. When you look at like the treatment strategy for blood pressure, it says to begin with lifestyle intervention. That's the very first step in the guidelines, is to move into lifestyle strategies.
I will say, let me interject. I've seen this happen once where diet and exercise did not work. And it was with my wife when she was pregnant. She got pregnancy hypertension, right? Or prenatal hypertension. And this is why she had to do a C-section, because her blood pressure after the first contraction, 185 over 145.
Wow. Nice.
Yeah. And I'm like, we're sitting here for 12 hours trying to get your blood pressure down. You're going in for surgery because I don't want to have a vegetable. Because if you have like 20 to 50 contractions before the baby is born, that's a guaranteed aneurysm with that much blood pressure. So this is because my wife has been training 2 days up until the pregnancy or the delivery. Not technically delivery, it was a C-section, but up until she was supposed to be due, 2 days before she was, going to the gym and doing cardio and eating healthy. And then her blood pressure started creeping up at the end. So that's the only context. Her estradiol was probably 50,000. Her growth hormone levels were like 15 to 20 milligrams per, or nanograms per milliliter. Like her hormone panel was sky high. We did blood work for her every month. You'd think she'd be on a full-blown steroid cycle. How crazy. Insane, man. Her growth hormone levels were like sky high the entire way through. It's amazing. Said I have to inject so much stuff to have it that high. IGF-1 levels was elevated. But you create an anabolic environment for the baby.
So can we back up? That's what I keep talking about, estrogen and IGF. The reason why it was elevated in serum is because her estrogen was going up like this during pregnancy, which binds the IGF in serum, which keeps it away from the fetus. So the placenta secretes IGF-2 to support the fetus. If the fetus were to get IGF-1 from the mother, then the fetus would grow too large and you would never be able to deliver the baby. So that's why IGF serum doesn't mean anything. It's not an anabolic. It's not a look into your anabolism. It's used as a metric for disease, right? We're looking at acromegaly, giantism, liver issues where children need Increlux because they produce growth hormone, but their liver doesn't kick out IGF. That's what the serum IGF test is used for. It's not used for bodybuilders or athletes, right? These guys hang on this stuff. I remember Chase Irons. I don't remember what his number was on a bottle of Serum a day. What was his IGF? 150, 200?
Yeah.
It doesn't make a difference what your serum IGF is. And you don't want it high because when it's on those binding proteins, each of those binding proteins will dictate where it's going to go in the human body. And muscle is not one of them, generally. It's going to go to bone and organs and other things that cause giantism.
Okay.
So that didn't mean that she was super anabolic from the IGF, right? It would be intramuscular that you're concerned with IGF.
Right. Okay. No, I think it's just the reason why our hormone levels were so high is that our blood pressure also
Yeah.
sky high.
Yeah.
And then of course adrenaline dumps. During the contractions. It's yeah. So that's the only time I saw that diet and exercise didn't work up until the last minute.
Like it
Whereas
says
I've-
here, I've got the international recommendations of hypertension guidelines. I can send you the citation and the picture, but like it literally says, for treatment, minimum standards of care, grade 1 hypertension is classified 140 to 150 over 90 to 99. And the very first thing it says is start lifestyle interventions. And then if concerned, start drug treatment in high-risk patients, those who have diabetes, cardiovascular disease risk, etc. But if you have stage 2 or grade 2 hypertension, which is obviously the highest one, where you're above 160 over 100, it says immediately start drug therapy. It's not even like... because, I guess we never even discussed this in the beginning, it's not, when we look at blood pressure, it's not the blood pressure that we're trying to control. It's the diseases that come from the elevated blood pressure. So whether that's eye disease, kidney disease, brain disease, heart disease, the outcome of success with blood pressure management medication is reducing your risk of a heart attack, reducing your risk of, retinal neuropathy, reducing risk on your
kidney failure,
kidneys,
yeah,
kidney
yeah,
failure. So it's the failure rate of the organ or the success in offsetting that is what is deemed the most protective part of taking a medication. Right. So in that regard, coming back to the food and the lifestyle interventions, these are like even medically prescribed guidelines that we're talking about here that are core basics. Just tick these simple boxes like you go to sleep.
But the funny thing is, with these lifestyle interventions, general population is less likely to follow those suggestions, and thus prescription medications are just being prescribed like candy, whereas the bodybuilders, they should be doing that anyway, because without them, they're not really... Well, it was a drug culture now, right? Without them, they're not really in the health and fitness space. Because I would assume that most people follow a regimented diet. It's not true. It's not true. They still treat their body like general population, where they just eat out all the time and freestyle meal together, and cardio is maybe once a week when they go shopping, and then they're skipping breakfast, so it's fast cardio before they have like a crazy meal at Cheesecake Factory. 20 minutes of walking from parking to where the Cheesecake Factory is. Yeah, that's the weird thing. Like, I would expect people just to follow the lifestyle, and then you see that it's very unlikely that you need these kinds of blood pressure medication interventions unless you really throw the kitchen sink of drugs at it. And when does that really happen? At the end of the off season? Most people see, prep, but then because your blood pressure or your body fat levels are so low and you're so regimented, most guys go hypotensive.
Yeah, no, I just meant as far as throwing drugs at the...
Yeah, the drugs at it. Yeah, but most guys are hypotensive at the end of contest prep. Where I got to reduce the masterone because otherwise I just lose so many electrolytes. Or they have to, reduce the blood pressure medications because otherwise they get, dizzy. So at the end of the off season is usually where you see where people actually need it, and at the end of the off season is the time where I want to break a couple plateaus, so I'm going to go on the Anadrol train, Okay, then I get it. Right, the body fat is a little bit high. That fat is compressing your arteries, and then even though the lifestyle is still there, it's just the basically in stage off season where it is actually required. So besides the where can we classify then these supplementary blood pressure medications, Carditone, Hawthorne berry in combination with beetroot, that's mostly in the context of pre-workouts, though. All right, or you have it in that supplement of yours of the SN.
I think like what we originally said for Carditone, I think these are like B at the highest, C at the lowest, and in terms like you're slotting them in to make up for a deficit in nutrition. So if you don't like eating beetroot or it's not in your vegetable intake, a standardized beetroot concentrate or extract will give you this benefit. Sure, even taking L-citrulline, pure L-citrulline, 3 to 6 grams pre-workout is going to positively influence blood flow delivery during the training, but also offset some of the blood pressure management issues like you were talking about. And that is probably one of the most highest risk points of an off season or a very high level competitive bodybuilder's day is doing task failure sets on a leg press or squat or max deadlift or whatever, that they're driving up that internal blood pressure from obviously the strain that it's required to lift with the force required for the weight. That you're really looking at, how can I offset the damage that this training session might be doing internally? Because your blood pressure could be absolutely perfect the other 12, 14 hours of being awake because you're just sitting around eating food, sitting on a couch, sitting at a desk. It's when you get in and start really pushing your body. And, you know, everyone's been there when you're sitting in a leg press and you're gripping the seat with like full might and your face is bright red like a tomato. You're creating that much pressure naturally from bracing and pushing the weight that you really need to think, well, your body's designed to accommodate probably a certain level of stress like that from a fight or flight perspective. But doing that like day in, day out is going to create some level of shear on your arteries over time that we're trying to offset.
Yeah. I think cumulative, if you go to the gym 5 times a week, 1.5 hour sessions, and then let's say the last 5 seconds of your sets is, elevated blood pressure, like alarmingly high, you could probably add it up to a couple minutes over the week. And over decades of training, it's probably not a good outcome. That's a trend. It could be a training also. You know, I think it contributes. So I think if you take like beetroot and hawthorne berry and L-citrulline and maybe vasodrive AP, which has some angiotensin-converting enzyme inhibiting effects, it's like some sort of proprietary blend of proteins, amino acids. I think if you take that around the workout, it could be A tier, because you will really prevent your blood pressure from reaching alarmingly high amounts to the point you get a tomato face or nosebleed or hemorrhoids. Hey, it's not talked about, but dude, after years of consultation, Steve, why every time I do a leg press, I get my asshole explodes.
Oh, wow.
It's not talked about, but it happens, man. It happens, especially during prep where all these guys eating like chicken, brown rice, and broccoli. There's no stool lubrication. And then, of course, it pops when they go crazy, doing heavy stuff.
Wait, it's not good for you just to eat chicken and rice every meal? I'm kidding. It's a joke.
Well, it's probably better than
I don't know.
eating...
That's what they say on Instagram. It's better than eating McDonald's, but is it?
Yeah, well, better than eating,
No.
Sour Patch Kids.
Yeah. What does your digestion look like eating chicken and rice for 6 meals a day?
Well, I think the orange roughy diet, at least it's a little bit. It has something that inhibits like fat absorption.
Well,
or fat.
the sugar diet, you probably just shit all day long, right? It just
That too. Yeah. My shits were like legendary on fruit and honey and a lot of fiber, man. Fuck, dude. So where were we? So your nosebleeds, tomato face, or popping hemorrhoids. Yeah, it's not a good sign. But I think with some proper pre-workout formulas, it's you can mitigate all of that stuff. And I remember because I started training before there were pre-workouts, right? And then basically we would train during summer, and then it's hot, and you don't know anything about these electrolytes or managing your hydration, and you eat like a whole bowl of oatmeal before you start squatting with the belt. And I would have a nosebleed every time. It was just part of the game. And we just spit it all over, because you're breathing hard, right? So you have like a double nosebleed, and you're spitting that blood all over the wall, and we just preemptively had a bucket there. And it would happen all summer. And we didn't know any better. We're 17 years old, man, 18 years old, just egging each other on to do more squats.
I mean, Dan Duchesne's pre-workout existed back then.
Yeah.
What was it? Something orange.
Ultimate Orange.
Orange.
And Jack 3D with 1,3-D dimethyl.
But Jack 3D was after Ultimate Orange, right? Dan was like the first one.
He had ephedrine in there, I think.
Yep.
Yeah. And then some other stuff. And then Jack 3D had 1,3-DMAA. And man, that shit we used to order that from China, the raws, and then make our own pre-workout, and then put a little bit too much in there. Holy shit, man! It felt like drugs. Of course, everybody was, but it's the most potent vasodilator you can put it, or constrictor you can put it in a pre-workout. Yeah, your arteries look crazy.
Yeah.
So
Good
everything
times.
covering the like natural route, even though they do have promise. I guess
Yeah.
like I've seen guys reduce their blood pressure 8 to 10 points with our product. So
Yeah.
Hawthorne beetroot has its place because of what's inside it from a nutritional perspective to improve blood flow. There's other ingredients that we can incorporate. Like I said, most pre-workouts now, non-stimulant based pre-workouts or pump based ones are designed to improve blood flow, which would lower blood pressure. So I think tiering these, I'd be generous and go with B, knowing that they're readily available, don't cost too much in terms of like monetary cost, and the benefit that you might get from Reserpine and Carditone, or the nitrates and beetroot or arginine conversion from the Hawthorne. If it's going to lower your blood pressure by 8 to 10 points naturally, where you don't need to intervene pharmaceutically with the angiotensin system, I think it's a nice place to enter low, rather than having that mentality of straight in with medication. You're still staying in line with like lifestyle and dietary management strategies first.
Right.
When
I do
it's
think
low
we
risk
should
with them too, versus
low
pharmaceutical drugs.
risk, right? Yeah, unless you start stacking something like Grilamode nitric with Cialis, then you might get hypotensive during your workout. I do think that, like, if you take them in combination with lifestyle, so the diet, exercise, electrolyte management, all that stuff, they could be like a C to B tier. But if you take them as a pre-workout to prevent hypertension during the workout, I would actually give them A tier, because it could offset the needle between you having a nosebleed and an hypertensive episode and just being normal. Because when I took pre-workouts, I don't really take them anymore because I don't train that hard anymore. But when I used to take them, when I would go balls to the wall and do sets past failure, I would notice that my blood pressure would go up. Again, it's the only time that my blood pressure was an issue. And then you take a pre-workout, 1 or 2 scoops, and that issue is not there, or your blood pressure doesn't increase that high, which, again, in the long term, could probably protect your kidneys or prevent a nosebleed. Because I haven't seen any of these kids that are cracked out on pre-workouts, the pump products, have nosebleeds during the gym. Whereas previously, that was common in my gyms. But maybe I went to the crazy gyms.
Well, EQ, Anadrol, those things.
Yeah. A lot of guys on EQ and Anadrol too, yeah.
I think it's a rite of passage that we've all experienced. Where you're in the middle of a set and you just feel this warm little drip, and you're like, nope, that's not a snot. You're running to get
So
tissue.
now we're starting to, now the set starts. And then somebody with his like flip phone digital camera takes a picture of you. It's like this big. Yeah, good times, man. All right, so that covers the supplements. And then we have like a slew of medical interventions. We have the angiotensin converting enzyme inhibitors and the angiotensin receptor blockers and the calcium channel blockers and the beta blockers. Now, there's like 10 or 15 of each in each category. I don't think we need to address all of them. I think we should address the one that are either commonly used or has some unique characteristics. Back in the day, Lisinopril was pretty popular as a blood pressure medication. It got the job done. It was the only thing that people really ran because it was readily available. But people would get a dry cough, right? That's why people kind of went away from Lisinopril and moved over to Telmisartan. And then
there's kidney and liver risk with it too.
Oh, with Lisinopril?
Yeah. I mean, not common, but it is and that's what I meant. It's versus the natural stuff. You're not running into the risk of
with ACE inhibitors and ARBs. If you have chronic kidney disease undiagnosed, then it's not a good idea. You can't.
Yeah, like I can't use any of those drugs.
All right. Yeah, of course, because you only have one kidney, and there's some very low risk that it might actually cause issues with your kidneys, and that's documented with most ACE inhibitors and ARBs. Again, it's a rare risk, but it's not unheard of. Now, Enalapril might still have some merit here and there because its secondary unique characteristics is that it controls hematocrit and red blood cell count. So for the guys who have undiagnosed sleep apnea and use a boatload of EQ and Anadrol, that might be some benefit there, right, to keep their hematocrit in range. So if you have to go with the blood pressure medication and hematocrit and red blood cell count is high, and again, you're worried about that, then Enalapril 2.5 milligrams, 5 milligrams might be A tier because you get two beneficial effects, blood pressure management and hematocrit control. Even though there's a million different ways to control your hematocrit. But we'll save that for another tier list.
Yeah, we could do a whole one on blood because I think people misunderstand that whole.
Right, exactly. And it's good to do a reminder on that. But people are still worried about it. And again, you have the reference range. Not everybody understands the difference in hydration and platelets. And,
and also and ferritin, how that comes into play.
Exactly, right.
The
So
things
we'll save
people are
that.
not looking at. We do that another time. But the Enalapril also has risk of kidney disease.
Exactly.
Kidney damage as well. So they all,
So regarding the kidney damage and knowing that there's so many other compounds on the market, do ACE inhibitors still have a merit if needed? Or are we now pivoting more to ARBs?
I would go with option B.
Yeah, no. Well, again, we can share this from that recommendation guideline, but they are moving away from ACE inhibitors being the first line. That you start with an ARB, and then if you need combo therapy, you pick your second choice as either lowering the ACE inhibition, so you inhibit the ACE enzyme, or you use a calcium channel blocker, which then has other side effects as well.
Yeah,
but ARBs are the first line now from a medical intervention that should be prescribed to start.
Right.
And what you normally find now in terms of like general population, the most commonly prescribed one is Losartan is normally what is generally prescribed to normal people, whereas we've sort of fell in line with Telmisartan based on its half-life, its drug distribution, secondary benefits, of lowering angiotensin-2 activation of the receptor, and all the other antioxidant benefits, fat burn and whatever we've pulled out of space. But it's the one that we've all favoured towards, and it's nice to see that we're thinking outside of like the medical community and what is more appropriate for our population of people. But like you said, within each class, within ARBs, the sartan drugs, I think there's at least 10 within the angiotensin converting enzyme inhibitors. There's at least 8. We have a whole host of these drugs and have moved through different generations depending on how they partition in the body, how they're metabolized. Some of them act as pro-drugs and then they convert to the active drug in the body. If we were to pick one to start, then I think, starting at the top and blocking the receptor is a better strategy, in that when you block the receptor, you still allow what has been produced, angiotensin, to move around the body and activate other angiotensin-2 receptors. So obviously we're getting down into the nitty-gritty now of the 2 different types of receptors that exist, one being good, one being potentially bad, that you're still allowing activation of the good receptor.
Yeah, Dean and I did a whole video just on that on my channel a while ago.
Yeah, I'll link it down below.
And specifically why you shouldn't necessarily just be blocking that all the time, right? Because there's good that comes from it as well.
Right.
And so when we're looking at it, I guess it's again, by default, if we're going to choose this medication and we've got blood pressure over, that pre-stage 1, like we're at 140 over 90, and you've done all your lifestyle intervention, all the easy things we covered earlier, you go in with the ARB expecting quite a dramatic shift in blood pressure if it is angiotensin driven. And what we're really leaning into here is genetic expression of ACE2 in the lungs. And this is where, you get into arguments around like everyone should be taking an ARB regardless of their status. And you're disregarding that probably 60% of people don't have an angiotensin-2 problem in their genetic line, and the other 40% do. And then the other 40% epigenetically from taking high doses of androgens are influencing that RAS pathway.
People completely neglect the mineralocorticoid receptor activation, where the electrolyte balance is altered, which you can easily manipulate with dietary interventions. If you let's say you're on a good stack, right, of steroids for anabolism, off-season, contest prep. Is it the Renin-Angiotensin-Aldosterone system that really gets fucked, or the mineralocorticoid receptor pathway? I would say the second.
The second, probably, depending on the drugs, but more the second.
Depending on the drugs, right? But in a stack, of a couple different compounds really aimed towards anabolism, I would say that the mineralocorticoids and the balance that you change regarding your electrolytes, which could have a negative effect on your blood pressure, and again, burning through magnesium and faster than usual because you have so much skeletal muscle contractions, and losing the sodium and potassium because your dietary changes. I think that's more of an issue with bodybuilders than a Renin-Angiotensin-Aldosterone system. People understand that they need to control their estrogen levels, unless...
Do they understand that?
Unless there's a guy out there telling you to increase your estrogen levels, does have a negative effect on your Renin-Angiotensin-Aldosterone system, and then prescribe a medication that can modulate that.
Interesting.
It's like somebody has an agenda.
Interesting.
Anyway.
Either way, the irony of what you brought up there is either way you have to take a medication, whether it's the evils of ACE inhibitors or angiotensin receptor blockers, which they're not evil, but then God forbid you say the word AI to control the estrogen to manage the blood pressure. So the irony is you end up taking a medication either way, and you're probably, I'm not going to say have less risk, but if you're going to control your estrogen, you're going to have more of a global effect over other parameters like mental health, blood pressure, fat deposition, anabolism, physical appearance, moods. Just keep going on and on.
I mean, unless you're transitioning, I don't know why you'd want your estrogen so high.
I will say one thing. After I did that gyno protocol, right, where I just let my estrogen run wild, and I think the highest it got to was 225. Blood pressure was in range. Yeah, I felt fine though. I felt fine. Like I might have to double check with my wife if I was crying during particular movies or a little bit overly emotional. Mentally, I felt fine. Where was it going with this?
You were able to achieve a full erection?
I was able to achieve a full erection.
Was there a serious premature ejaculation occur?
Yeah, I was able to grow my gyno to like legendary proportions, or even the surgeon was like, bro, I only see these on obese people. Yeah. I haven't gotten acne since.
Since lowering it?
I always had since that time. So, and my wife noticed the same thing during her pregnancy, where estrogen was undetectably high. So everybody always gives estradiol, and myself included, estradiol or hormonal fluctuations that it causes so much acne. Right? My wife had zero acne during her pregnancy, and now it's slowly coming back now that her estrogen levels crashed. I mean, that's an estrogen crash from like undetectably high, and it drops 90% in 3 days. Insane. No wonder there's postpartum depression. Anyway, and I'm controlling my estradiol levels now, but I had my estradiol high for like 4 months, didn't have any acne, and haven't had acne since. So there might be something to say in that regard. Grow your gyno, get rid of the acne if that's an issue for you. I had one pimple here, some small one. So, but that's the only thing that I noticed. Maybe at one point during time, you could ramp your estrogen really high if you can deal with the side effects. And then if you're acne prone, it might get rid of it.
Possibly. I just don't know.
Possibly, yeah. But two, an anecdotal of two. One on steroids, one pregnant.
I would think the risks of the high estrogen would outweigh any zit right. Carditone.
Yeah. Well, that can also cause issues. Well, we'll address that during the tier list, during the acne tier list.
It's probably a liver metabolism problem when you look at it, because when you have estradiol, then you have estrone, and then you have the 2-hydroxy, 4-hydroxy and then you have the methoxy counterparts that COMT methylates. I know from personal experience when my estrogen goes extremely high, and that's just with 125 tomatoes, that with my mood completely changes quite quick because genetically, I've said it to you before, Steve, about having a very fast MAO-A enzyme that just burns through serotonin.
Right.
But one of the things that keeps up with serotonin's demand then, or most of estrogen, is methylation. And then you end up with a scenario where you've got high estrogen, and now you've got a blockage in your estradiol metabolism because you don't have enough folate metabolism. Right. And I wouldn't recommend this to anyone, but there's times in the past where I've ran like 15 milligrams of methylfolate, like max high clinical depression dosage of methylfolate to break through that methylation barrier while bringing estrogen down. That when you have high estrogen, you're putting huge demand on SAM-E and your methylation to clear the estrogen as well. So that then causes all sorts of imbalances in your neurochemistry. So it's really important that, like we've said before, it's like Goldilocks. You want just the right amount that it serves your body physically, mentally, and everything else without fluctuating like a sky high, and now all of a sudden you've got blood pressure problems or mood issues, or too low and your joints feel like absolute crap.
Yeah. And for most people, that seems to be towards the top of the reference range or slightly over it. So we're talking about 35 to 50. And then after that, most guys start to get side effects. I was surprised that I was mentally stable and that my acne went away after the high estrogen. Now, I'm not sure how much the trestolone and the DECA contributed. But you would say that on a stack like that, no AI, like high test, high DECA, high trestolone, estradiol through the roof, that I would be pimpled galore, but it actually went away. So it's counterintuitive, but sometimes shit happens. So I'm actually happy that I did this experiment. Where were we? Oh, we were talking about Telmisartan.
Yeah, for Telmisartan. I guess if we look at, let's say someone does have the genetic basis, so they have angiotensin 2 issues, straight away Telmisartan from a tier perspective would be S. Like it's the most available drug to you. And people are going to be shocked. Dean is recommending Telmisartan in S tier.
Somebody's screaming their pants in northern Thailand right now. 100%. He's going to clip this. And see. Even Dean said it was S tier.
Does he watch this?
Oh, trust me, dude. He watches everything I do.
So in that instance, that is perfectly suited for that case-specific person, which is why I've said all the time from a pharmacology perspective, pick the drug to match the person. No, take the drug just because. So
because you heard it on YouTube?
Yeah, because Shitfluencer XYZ said it.
So in that regard, if they do have these genetic problems, and another like side point I've often said is we have 2 medications I believe have been developed to address root causes of disease. Angiotensin converting enzyme inhibitors or receptor blockers go towards the genetic aspect of ACE2, and insulin. They're really the only 2 that go to the root cause of, you've got type 1 diabetes, can't make insulin, here's insulin. Got genetic problems with ACE2, well, unfortunately, there's nothing we can really do, regardless of your dietary intervention and this, that, and the other. You are going to be hypertensive, so we'll block the enzyme or we'll block the receptor to offset. What we covered was the risks of high blood pressure causing disease, not the risk of the high blood pressure itself.
Right. And it seems that African Americans have a higher likelihood to have this genetic issue than Caucasians do. So dietary and lifestyle interventions aside, they are probably more likely to end up on a medication like this when they do heavy cycles.
I mean, even personally speaking, my dad is African. He's from Mauritius, so I'm half African and my mother's Irish.
Nobody would tell, dude.
No. When people see the picture of me and my dad, it's like, geez, man, who's that guy? I still have a running joke with a friend who still doesn't believe he's my dad. But anyway.
Honestly, I think if you move countries and you expose yourself a little bit to sunlight, not this UK sun that doesn't give anybody a tan, I think you can get dark.
Me and remember last year when I came back from vacation, I changed species. But like my grandmother and my dad have to take combination blood pressure medication because of their genetics. And like this, my dad, who's like 72, 73, goes to gym, eats right, does everything, typical sort of like Asian, African diet. But like my grandmother, her blood pressure was sky high, even with medication. And I guess it comes down to then like the tolerance of the body to the high blood pressure and what diseases come from it and how the body's compensating for it. But then like the other side, you've got my mother who has extremely low blood pressure that I've inherited, that if I take any close to the dose of what my dad has taken for his blood pressure, I'd probably be on the floor, or I'd have a very difficult time getting up out of a chair. So genetically, yeah, it looks like those of African descent have a higher risk of higher ACE2 production.
If I have to look back through all my coaching logs, I mean, I didn't coach that many African Americans, but a large portion of them needed some sort of blood pressure medication, and that they're following the lifestyle just like everybody else. And so some sort of blood pressure intervention was in place. And that's why I always wonder, like some of these guys at the pro level, if they were doing that or not. It's why they seem more susceptible to kidney issues later on in life. So yeah, that might be a genetic thing that people need to pay a little bit more attention to. And again, you can't do a 23andMe nowadays, but you can just buy a risk off and keep track of your blood pressure and see how that changes as you add in particular compounds.
Yeah, it's non-negotiable.
Yeah. And again, some people don't respond well to telmisartans, and that's why we have valsartan or losartan as alternatives. And then you lose out on these trace beneficial effects that telmisartan might have, like a PPAR receptor activation and 0.05% additional fat loss or metabolic boost that you can get from the daily fasted cardio.
I guess the other side
effect.
effect.
Fucking Carditone, it gives you cancer.
Did we ever bring it up? I think I brought it up with Kurt when we discussed it. Well, that ARBs, if they make you shit yourself. One of the side effects of ARBs that we potentially believe is leaky gut as well. They literally create junction gaps between the epithelial cells of your gut, which then opens up a whole other host of issues. So leaky gut is one side effect potentially of ARBs that if you're an off-season
and then there's liver
bodybuilder-
issues like Ben Chow, for example. He started
kidney issues as well.
Yeah, and kidney issues like Ben Chow. He got liver issues right away.
Really?
From the telmisartan. Yeah, it's his liver enzymes were sky high. It's like, you can't use this. And then everybody gave him shit. Yeah, but this is the medication to take. So, well, shit, sometimes it happens. There's a lot of drugs I can't take either. I could take a lot of them, but not all of them. And then you just have to make the adult decision. Said, this drug is not for me. I'm going to look for a replacement. And if that doesn't fall in line with the rest of, the regurgitation in the fitness space, so be it. You have an individual body that you need to address individually with the medications, if needed, that match with you. That's why it's so much fun trying to figure it out. And there's always Cialis. Like telmisartan, again, it's S tier if you need it. And Cialis is also great. I think that's S tier also. It can lower your estrogen. It can improve your testosterone levels. It can give you massive boners. It can help with the pump. It's a multifactorial blood pressure medication that has so many multifactorial benefits that it was prescribed as a dick pill. So a lot of people control their blood pressure with Cialis. The downside is acid reflux. You take your Cialis with oral steroids, you're going to be burping acid the whole day unless you take a proton pump inhibitor or increase your stomach acid with betaine hydrochloride and apple cider vinegar. So that also comes with a little bit of an instruction manual. Low dose, 5 milligrams Cialis, 10 milligrams if you're a big guy. I think you can do a lot of good, but also a lot of harm. Do you guys have any experience with Cialis as blood pressure medications or recreationally?
Yeah, everyone's tried it with the pump. It's an experience. If you stack another few things on top of it, can be quite the experience training arms or training chest.
Yeah.
I think from a blood pressure perspective, the knock-on effect of CGMP and raising, endothelial nitric oxide production you're probably only going to see maybe a drop in blood pressure of like 4 or 5 points. Now, that might be enough to take you from 140 down into 135 or 135 into 130. But then you're getting all the other potential benefits. It has a long half-life. It can be used maybe once, twice per week. I see it quite often being prescribed by TRT clinics now as an adjuvant for blood pressure management alongside TRT, because in the UK it's relatively cheap. On a private prescription perspective, that adding 1 or 2 pills per week to a TRT dose gives the benefit of satisfaction in the bedroom, but also blood pressure management, and then you carry that into the gym.
Yeah. Yeah, a lot of guys are more, like when they start this journey of TRT, they're probably more receptive to adding something like Cialis because they heard about that. Like Telmisartan, we all know about this in the bodybuilding space. But Cialis is, of course, legendary status with general population where, it helps with erection quality and might help with libido because you have more confidence in your erection. And in that sense, they'd rather run that. And the blood pressure management is a warm added benefit, which initially that's what it was designed for. Yeah. But they prescribe it for its side effects, basically. And you could microdose, Viagra or Levitra. You could microdose those because they have shorter half-lives. Yep. So you would need to take those once or twice per day. Or twice per day.
There's like dietary restrictions too with those versus Cialis, right?
Oh, really?
You don't take Viagra with fat in a meal. It's not
right, yeah, because I didn't.
I'm just saying you have to time it correctly. There's,
Yeah, Cialis you could take once per day.
It's much easier to use.
Yeah, that for sure, and it has a compounding effect. So what a lot of guys notice is that they start with 5 milligrams, and then after a week or two, it really reaches peak serum levels, and they get a little bit of this flushing effect where the capillaries dilate. And then you get a lot of blood flow through the face, and then it feels like you stuck your face in a hot oven. And you get the same effect with Telmisartan when you start that at 80 milligrams per day or 40 milligrams per day, because you get that capillary dilation, and then your face gets hot. You can really feel that in your skin. So there's a lot of side effect that people don't really expect, and then suddenly that happens when they first use these medications. Your body slowly adapts to that, or you adapt to the feeling. Or this heat that you get through your skin is a little bit more pronounced than before due to the blood flow. Same thing from red wine, right? What is it? Resveratrol. So, Dean, if you drink red wine, are you on the floor from hypotension?
Me? I can't remember the last time I drank red wine. It must have been when I was in college.
Yeah.
Jesus, that must have been like 15 years ago.
Right. So with red wine, you have the resveratrol, right? And it can also have a dilating effect. And then people get red ears from the capillary dilations. And that can also lower their blood pressure. And that's how a lot of alcoholics justify their wine consumption. Because it's good for blood pressure. It's nothing different than some guys.
It lowers cholesterol, too. It doesn't mean it's any good for you.
It's dissolving your body from the inside, the alcohol. So that's... so where can we put Cialis in the tier list? Do we put it over Telmisartan, same rank, A tier? I think it's 8. Yeah, I think it's A tier. I like it. I like actually look into Cialis before looking into Telmisartan because it has more practical benefits.
Yeah, well, I guess one of the things that causes impotence is high blood pressure. Ironically, ironically, so you're probably going towards that root cause, taking something like this. And it probably falls in line like the pre-workout supplementation. Like as much as we see it as an erection performance boosting drug, it has these benefits of performance-based aspects in the gym that people are biohacking with it from a PD perspective as opposed to even thinking of health benefits. And that just carries over. Then when you go to the gym, like we're talking about, you're lowering your blood pressure from one aspect. Just don't get sexually stimulated in the gym.
Yeah. Oh, yeah, you get the boners in the gym. Yeah, nowadays there's so many OnlyFans girls in the gyms. It's you really got to select where you do your training. Oh, my God, man. So it's fucking shorts wedged up all the way to the fucking... You guys know. Yeah, I'm here to train. If I want to see that, I'll go to Pornhub. Please. Stop it. Especially when you're Cialis. Yeah, it's a loaded weapon, man. But yeah, I would rather have people look into Cialis as like the first line of defense of blood pressure management than Telmisartan. Because again, from a practical perspective, it has more benefits, and the Telmisartan benefits are mostly on paper. It's a lot of mental masturbation when it comes to the benefits, the additional benefits of Telmisartan, and how much that really plays out in the real world. Like people, again, they hammer on the PPAR receptor agonism, but how much metabolism boost or fat loss you get from Telmisartan, I think it's negligible. I think growth hormone is a better fat loss agent, and that's a very expensive fat loss agent. For what it is. It's not Clen. It's not SLU. It's not, these other fat burning aids that we have at our disposal.
You're saying SLU versus growth hormone?
Yeah, I think SLU burns more fat than growth hormone from a finance perspective.
Pharmaceutical growth hormone, I would disagree with that. And the dose.
Yeah.
In the dose
we're talking about, yeah, of course, it's a dose-dependent manner. Yeah. But pharmaceutical growth hormone, if you look at the cost of what you're spending.
Yeah. No, I'm just saying from a fat loss point of view, I don't think anything's going to burn fat and preserve muscle as well as
Well, we're talking about Serostim specifically here, right?
Or genotropin, omnotropin.
Yeah.
Right. Just saying, you use enough pharmaceutical growth hormone, you can eat whatever you want.
Yeah, true.
Unless you were born with very odd genetics.
That's also true. Yeah, but you really need to run a substantial amount of GH. Yeah. We're talking about HIV, close to HIV patient dosages. Yeah. And that's for most people unaffordable, or they can't deal with the carpal tunnel.
I was just saying, yes.
I know. I've been there, and I will agree. Like if you go with the HIV dose, then you could just do whatever and still get lean and basically mutate. But it's either unobtainable, unaffordable, or the carpal tunnel, which potassium solves.
Well, I was going to say, yeah. And with the pharmaceutical growth, there shouldn't be the side effects, even at that dose. Those go away. It's temporary.
Really? How long do you need to run it?
I don't know. I've been on it for years. I don't have any.
Yeah, okay, yeah, years. I wonder how long it would take for a beginner to kind of ramp up the dosages. And then
when I ramped up, I went 3, 6, 9 to get to 9, and then I had to go back to 6.
We're talking about milligrams, guys. The true indication.
Milligrams. No, I was talking about IUs. Sorry.
Oh, really?
I went 1 milligram, 2 milligram, 3 milligram.
Fuck you, Kurt.
9 IUs, and then
3 milligrams and 9 IUs.
No, because 9 milligrams of growth hormone. 9 milligrams of growth hormone is a lot.
Okay.
Back to 6 for a couple weeks, and then it was transient on occasion. Like you'd wake up sometimes and one hand would be numb, maybe the way you were laying on it. But I haven't had numb hands in 2 years from it.
Okay. Yeah, but initially you had it.
Initially there's some, but it goes away when I feel like with the UGL stuff, with the binders and stuff, it doesn't really go away. It seems to, as they ramp the dose, if it gets worse and just kind of sticks around. Yeah. And I haven't been below 9 IUs or 3 milligrams in 3 years.
Okay. Yeah, and you eat whatever you want.
I mean, I choose to eat clean.
Still
and
healthy,
I don't eat. Yeah. I mean, could I? I'm sure I could if I chose to.
I wonder what would happen if you go to Disneyland with the family and just eat. I
lose weight on vacation.
Yeah, I thought so.
Because it can't eat enough. You're walking around and you can't actually eat enough food. It's just garbage food, but you're not eating enough of it, right? Because you get full, you eat that shit, and then you're full for 6 hours, and you can't even get the food in.
It doesn't digest. Yeah,
no. I don't know. I'm the opposite. Like I'll lose weight. Even when I went to Vegas with you guys, I lost weight.
I lost initially, and then I gained.
Did you?
Yeah, but I can eat like a fucking maniac, and it's I mean, I'm in the U.S. I have like 10 days to eat garbage, so I'm gonna eat all the garbage I can see, and then I have to go back to Thailand where the garbage is non-existent. Oh, there's garbage here, but it's not as garbagey.
Yeah, it's not as garbagey.
A lot of garbage. That's why I'm not going this year, so I can actually, not get fat, and I have to do a binge and purge. Where were we? Cialis. Okay, so Cialis, let's put it in A tier. Even though I would say it's the first line of defense against high blood pressure if all the other stuff is not working. It's probably a better introduction into blood pressure management than Telmisartan.
Yeah, because then, I mean, from there on, you've got like the other things like Lisinopril, like the ACE inhibitors, calcium channel blockers, that from a mechanistic perspective, you know, the side effects that come from them, the actual outcome of how protective they are, to me, they're more like adjuvants that you require for combination therapy. But the combination therapy, you should only be really stacking like multiple blood pressure lowering medications if you're in that like stage 2 hypertension, which is like above 160 over 100. And at that point, if a lot of it is drug induced from sky high dosages of androgens, probably reduce your dose rather than
No, I don't want to hear it. I don't want to hear it. I don't want to hear it tell me get off the 150 milligrams Anadrol per day. Come on now, man. We're bodybuilders. We got to ramp up the dose and
add more drugs.
Take the ancillaries to deal with the side effects. If that means an ACE inhibitor and a beta blocker and
diabetes drugs and insulin
I mean, my drug
use an
is
AI.
already...
Never use an AI, though.
No, never use
the other
AI.
90 drugs to manage everything else. God forbid the AI will cause harm.
And Cialis and Telmisartan increase aromatase enzyme expression, wasn't that the case?
Yeah, they can increase estrogen, Yep. We brought that up before. I mean, isn't it paradoxical? Imagine you started a trend where you just set up the dose, and as you keep upping the dose, there comes a point where it's an inverse curve where your blood pressure gets sky high that actually goes sky low.
Same as Carditone, where the dose, the anti-cancer. Yeah, I'm serious. I did a deep dive on Carditone, and you find out that the anti-cancer dose is higher than the cancer-causing dose. I'm like, what the fuck? 18 studies show that it causes cancer at this dosage range, and then the anti-cancer dose is higher. So first you got to give yourself cancer, and then you ramp up the dose, and it can take the cancer away. What the hell? It's so prolific that it eats itself.
Yeah, you smoke a cigarette the normal way, and then you flip it backwards, and you smoke it the other way. And it gets
Yeah, but you exhale.
you just blow through the cigarette.
But you keep the ash in your mouth. Yeah, keep the ash in your mouth. And they use methylene blue to kind of taint, clean it up. Oh man, we're going more off board.
Nicotine's an AI though, so I mean, you could just.
Oh yeah, the cotinine and the anabolic, the metabolites and the nicotine itself, it acts as an aromatase inhibitor, and it has anti-cancer properties.
And smoking definitely does not raise your blood pressure.
No, not at all, man. No. That's why all these guys pop Zins pre-workout.
Yeah. Watch, now smoking's going to be a trend, thanks to me.
A lot of people still smoke, man. It's crazy. I used to smoke too, but I quit.
Do they in Thailand? Is it big there?
It's a lot. It's a lot. They're smoking in front of the gym now.
Oh, shit.
But those are mostly Chinese.
Okay.
I don't know. I think Muscle Factory got into some sort of Chinese Bobe or whatever app they use. That's like the best gym in Thailand. So all the Chinese people start showing up in the evening. They're all fucking chain smoking in front of the gym. And I just gave up, man. I couldn't. One time I went out with a barbell. I said, hey, next time I'm going to park this barbell in your mouth. See if you can smoke them. But I couldn't understand because they didn't speak any English. And then the owner was like, hey, slow down. It's like, fuck, get these people off the property. Oh, that's what I have to deal with. So let's see what's last on this list. Oh, yeah, beta blockers. Nebivolol, propranolol, that kind of stuff. I think those are really the last resort. I do like Nebivolol, though, but again, it's only during the off-season. And that's not necessarily to control my blood pressure, but just to prevent left ventricular hypertrophy when the training intensity is so high. And then the downside of Telmisartan and Nebivolol and many of these blood pressure medications is hyperkalemia. And when you're taking a good amount of potassium, hyperkalemia can be a real concern.
Mm-hmm. Yep.
Now, what a lot of guys are going to do is then lower their potassium so they can take the Telmisartan and the Nebivolol together, when in reality it's just keeping your potassium intake consistent so the excretion is consistent and it doesn't build up in the bloodstream. So we're circling right back to the electrolytes. Keep your electrolyte intake, your diet, and your low-sodium potassium salt or your new salt or your hard salt intake the same.
But then
And
you're
then-
forgetting another class of drugs used for lowering blood pressure.
What, the calcium channel blockers?
Diuretics. You just piss out the hyperkalemia.
No. Like those obese. Yeah, I take Lasix every morning to control my blood pressure. Fuck you, fat bitch. Jesus Christ. I don't know why I pee so much. So why cramp? My hands are cramping when I play video games. Fuck. Imagine if there was an educator out there just continuously prescribing you to take Lasix.
Oh, someone's going to now. Watch.
Yeah. I mean, I do know guys that use hydrochlorothiazide chronically.
I mean, look, we had an influencer that thought halotestin was safe for women and children. So
Yeah, that's true. Yeah, I guess it never ends, man. It's good. Do you guys go to TikTok?
I haven't been on there in a long time. No. Why? What's on TikTok now?
Don't. Just don't. I was talking with Anabolic Pharmacist, one of the sources, right, the affiliates, and he goes to TikTok and he's like, dude, it's like everybody copies the Anabolic Roundtable, but they do it wrong. And then everything you guys introduce, and they get thousands of views, Steve. And they want to sign up for my affiliate program, and I don't let them. Fuck these guys. They're fucking trash influencers, man. They're talking about SLU and MOTS-C and combining tren with anadrol, but they don't know how to explain it. He was getting so pissed, man.
Nice. It's good to see we have an influence on people.
Oh, we have an influence on the influencers, yeah. Yeah, but they need to watch maybe 2 or 3 times before they regurgitate.
Yeah.
Yeah, so the Lasix, I don't think that's a valid, or diuretics, I don't think, aldactone, right? I don't think it's a valid way to control your blood pressure.
No. But in the scheme of it, when you're looking at combo therapy, like what we said, it's ARB, then an ACE inhibitor, a calcium channel blocker, and then the triple therapy is hydrochlorothiazide on top.
Yeah.
But we're looking at general population here who don't manage their electrolyte balance, so they're taking the diuretic to manage sodium loading from their nutrition.
Yeah.
So that I was only joking about diuretics because we're talking about adding more and more drugs. That diuretics should not be used to control blood pressure, and put any influencer promoting them for lowering blood pressure in the bin.
Yeah. Unsubscribe, unfollow that bullshit.
Yep.
I mean, I think the longer we do this in our space, the less we even recommend diuretics, even for contest prep, because it just makes people flat and it's very unpredictable, you know. And again, when you're truly in shape, you kind of don't need it. It's just,
You don't need it. Where's water going?
Yeah, it's from the muscle.
If you get
it's not
fat,
coming from this.
Well, if you get fat free, you don't have a ton of water under your skin.
No. So the only real way of recommending diuretics is for people who did not get in shape or thought they were in shape, and then they backstage they're like,
or make a mistake, right? Insulin.
Yeah, make a
carb load
mistake with the
mistakes.
insulin, the carb
Sometimes,
loading. Okay, fine, a little bit of injectable Lasix. It's not like I've never done that to people, but it's because they were not fat-free,
Yep.
you know? And the guys that had to make a weight class and they're, 2 kilos over, and the only way to get them down is to starve them down, they're fat-free. You don't need to use anything.
Yeah,
How can he fit into the class?
he
didn't use diuretics for the weigh-in, sucker.
We talked about before, even with my own prep, like with varicose veins and venous flow issues, using like a quarter of a tablet of diazide, the triamterene and hydrochlorothiazide together, a quarter at some point in the middle of the night when you get up to go to the bathroom, so as a half-life of action of like 12 hours. It's just ensuring that if you do have varicose veins or venous insufficiency, some fluid that might pool around your legs and blur some detail, as you start drinking fluid on contest day, you're matching the excretion of the ingestion of fluid.
Exactly, yeah.
But like even then, like on contest day, coming back to electrolytes, last year I never ate anything on contest day. What I done was I drank like my intra-workout drink, which is highly branched cyclic dextrin, and then 4 servings of our electrolyte products. And then Electrolyte Plus had 510 milligrams of potassium per serving. So before I got on stage, I had 2,000 milligrams of potassium from an electrolyte supplement alone, that there was no way I was getting on stage flat because you're hydrating with the fluid, you're hydrating with the electrolytes.
Yeah,
So,
once the carbs are in, and like it's not like you're a mass monster where you burn through the carbs and you need to replenish that. As long as you're resting backstage and your pump up is not crazy, then you're not going to lose any fullness from a glycogen perspective. You know, because most of the time backstage, well, what are you doing? You're just sitting on your ass. You're just laying down, you know, in your little inflatable mattress.
Yeah.
Like the mass monsters, okay, they're big. They need to eat some food. But if, you know, for your weight, I think fasting up until prejudging is fine.
it's better luck as well.
It's
But
better-
yeah, I
It's,
think
it's you know, less water retentive around the waist, and no chance of having a little bit of a digestion crisis. You can pull a deep vacuum, and again, it's not like you need to top off the glycogen because there's less inactivity.
Yeah.
And then you can fill out for finals. Okay, cool, because you just had a couple of rounds of posing. Right? Then you're losing some glycogen and some fullness. Plus, it's finals. Fuck it, some veins.
a bit of fun.
Yeah.
So
exactly.
I think like with the beta blockers, again, very case specific. Resting heart rate would be a big like confounder to whether you choose to use a beta blocker or not. Thyroid hormone status. It's very like specific again because we're going back to maybe some level of adrenaline induced hypertension or catecholamine induced hypertension that we're trying to reduce stimulation on the heart so that everything slows down. But coming back to like Kurt said, like blood viscosity, we want to make sure that everything from a hematocrit perspective is optimal, because the last thing we want is very viscous blood, so really high hematocrit, low blood hydration, and now you're slowing the heart down in order to reduce work that the heart muscle is doing, but now it needs to try and compensate for that slowed electrical activity by using more pressure to push the blood around. So it comes with a bit of a trade-off when you go down the route of using beta blockers for offsetting like LVH or hypertension-induced cardiomyopathies.
Yeah, all the other stuff needs to be in place. That's why I would say Nebivolol is basically the end stage option you need to look at. Because again, you can manage your heart rate with daily fasted cardio. Yeah, fuck. God damn it, Steve. And just a healthy lifestyle. And if you use all these fat burners, obviously, right, Nebivolol is not going to offset the heart stimulation effects from GLP-1s or a thyroid medication. Okay, clenbuterol, sure, right? It's working on similar receptors. We have mirabegron for that. We have SLU. We have other fat burners that are non-stimulatory or minimally stimulatory. So if that's an issue, then, well, again, you take a drug out instead of keeping the drug in and then putting an ancillary in place to prevent the side effects of that one drug that you're taking 120 micrograms of. It's not rocket science, guys. So I think they do have their place. But again, I would only use Nebivolol at the end of an off-season where the abuse in the gym and the body weight is so high.
Yeah.
And that maybe daily fasted cardio is not sufficient enough to keep your resting heart rate going because the body weight increase was so substantial. And again, you can grow slower, obviously, but that's usually for seasoned competitors. In the beginning, you want to get up to 300 pounds or 265, whatever. And then I think 5 milligrams Nebivolol goes a long way. And we're talking about 3 months out of the year that you might have a beneficial effect out of it, assuming you check your potassium levels before, during, and after, because it can be an issue. So I would put it in C tier.
Yeah,
because it's like middle of the road. Not really sure when to or there's limited practical applications, and even then it's end stage application, while everything else needs to be in place. Just cherry on top stuff, basically. And again, it can slow your metabolism. And otherwise, look at something like propranolol. So, if your leg day is very violent, and you're taking a whole pre-workout ritual and your adrenaline levels are sky high post-workout, then look into propranolol post-workout, where you bring yourself out of this sympathetic drive and allow you to sleep and recover and rest faster. And then you don't really take it as a blood pressure medication, but it's more as a recovery aid, where you bring the adrenaline down and the cortisol down. And again, you take your propranolol with your growth hormone and then shut the fuck up and go sleep.
I guess that falls back to the earlier pillars, that sleep is another magic for lowering blood pressure and improving resting heart rate and heart rate variability. That if we are jacked up on loads of stimulants and everything else, that's going to negatively affect your blood pressure in that aspect. If you're not sleeping properly, cortisol rises, cortisol causing blood pressure problems. So yeah, sleep, your propranolol if needed, your growth hormone, other things to help you have good quality deep sleep, your CPAP with your mouth tape. We're going back full circle here.
Yeah, so sleep, cardio, and electrolytes and diet, all S tier.
Yes.
Telmisartan, we can put an S tier if you need it, and then everything else kind of falls under that.
Yeah.
Again, somebody creamed their pants just now. Happy to oblige. Somebody needs a little win here and there after a decade of failures. And I don't think we even have time for kidney stuff, because it'll probably takes another 2 hours. So instead of addressing the kidney tier list, which again, there's not so much, but I'd rather spend the time on it next month than rush through it now, because we're already 2 hours in. So maybe we can do like an F tier list for things that are deleterious for your kidneys. Now, of course, eating like an asshole, we all know that doesn't help. And the opposite of not sleeping and not taping your mouth and, not taking the electrolytes, it's obviously all F tier behavior. But maybe we can classify a couple performance-enhancing drugs in F tier that are certainly or very likely to have a negative effect on your blood pressure, even if you're doing things right. So we're talking about high-dose Anadrol, maybe Trenbolone, right? Kurt, in your opinion, which compounds should be respected when it comes to blood pressure?
Yeah, because we're talking specifically blood pressure then causing kidney damage, not the drug causing kidney damage directly.
Exactly. Yeah. Okay. So
I just want to clarify that, because people always make these assumptions that EQ causes direct kidney, like that's based on like one case study.
No, well, I did a deep dive on it.
No, I'm just saying, but I want to make sure that I'm clear. It's usually blood pressure.
It's just
first.
Blood pressure, just regarding blood pressure. So, right, boldenone,
testosterone in huge amounts, right?
Yeah.
Mm-hmm. Estrogen, obviously, if it's elevated. Trenbolone, Anadrol, D-ball.
Yeah.
What else would is halotestin? My blood pressure was always low at that point in prep. Halotestin probably has a pretty profound effect on blood pressure.
If you take it during powerlifting meets, then
I was going to say, if it's used for strength, then yeah, it probably does.
That's a guaranteed nosebleed right
What else am I missing?
Trestolone is known to increase blood pressure.
Okay. I guess Nebivolol can too, depending on the fluid level.
So scientifically, I was actually preparing for like a little bit of a deep dive regarding blood pressure, but it's with my rate of producing videos, I figured this was a little bit faster to get your guys' opinion chiming in. So scientifically, testosterone, nandrolone, winstrol, Anavar, Anadrol, boldenone, Trenbolone in some animal models. Again, no scientific evidence. Turinabol, Dianabol, basically everything.
Turinabol, okay.
Except for Primabol and Amastrone has been...
and Anavar.
Anavar also, yeah. Anavar. Basically everything Mastrone and... let me double check. And Primo was shown not to have...
it's interesting that Winstrol would.
Yeah, so there's some scientific evidence that shows that even Winstrol, because it is used for... what is it called?
Chronic angioedema?
Yeah, chronic angioedema. And the funny thing is, Turinabol actually acts as an aldosterone synthase inhibitor. That's why a lot of people get cramps, which should technically modulate your blood pressure by promoting sodium excretion.
But in practice, it doesn't do that.
Yeah, in practice, it doesn't do that. So again, it's like nobody ever reported hypotension on Turinabol, even though technically on paper there should be some blood pressure lowering effects if you're throwing the kitchen sink of sodium at it. So actually, stenbolone, also no scientific evidence. Yeah, but that's because there's no study. Same as dihydroboldenone, right? There's no scientific evidence anywhere to be found.
But it's interesting then, is this like from a mechanism perspective as acting as an androgen, or is this like global? Because obviously as an androgen, you're looking at more so like angiotensin 2 or the angiotensin 2 receptor. But globally, you're looking at factors like mineral corticoid expression or retention, cortisol and dopamine and catecholamines, oxidative stress or lack of antioxidants to protect your epithelial cells or your endothelial nitric oxide production. All these global things that I'm not sure if you could classify like one androgen over another as being
because
more,
it's also dose dependent, right?
as being more like F tier, that take this in your kidneys. I guess from a blood pressure perspective.
Yeah, mostly from a blood pressure, but we'll save the kidneys for the next time because I want to do a whole tier list on that, and I don't think we have time for that. We're already been recording for 2 hours.
With the kidney,
the audience retention is like 2% right now. So.
And we appreciate you.
We appreciate all of you 2%ers out there.
I guess from
5-minute crew.
from that aspect, like if you're going to put like a bucket list, like a bin list for steroids for F tier towards kidneys.
No, blood pressure. Just blood pressure.
Blood
just
pressure.
Blood pressure. Yeah.
Blood pressure. Then you could pick.
Let's put it this way: we run an effective dose of a steroid where we get a good response, minimal side effects. Which of these are very likely to give you high blood pressure, even though we're keeping the side effects low? I would say Trenbolone, an effective dose of Trenbolone will probably raise your blood pressure. Anadrol,
EQ,
EQ,
Winstrol,
and Winstrol. Okay. And I would add Trestolone to that. Those 5. Yeah. I would say, because my blood pressure increased after going on the cycle again. So I would say 5 compounds. Nandrolone, effective dose is 100 to 200 milligrams a week. I think blood pressure changes are minimal, right? TRT, up until 500 milligrams. I think you need to run a gamma test before your blood pressure really goes up.
That's why I said test in a big amount.
Yeah. And even if you control your estrogen, you can mitigate that. So with Trestolone, it seems that even if you mitigate your estrogen, it seems that it increases your blood pressure. But with nandrolone and testosterone, that's not the case. Now, Primobolan, Mastrone, I think you're not living the lifestyle if it increases your blood pressure. Anavar, probably not. Winstrol, yes. Anadrol, very likely. At 50 milligrams per day, I think you can see some changes in your blood pressure, and especially if you go to 100 milligrams per day, which is where the fun happens. Let's be honest. And then Trenbolone, well, we're talking about 150 milligrams a week. I think you're the same as Trestolone, 150 milligrams a week. I think, that's where most people start to notice like good effects. Of course, you can run 20 milligrams, once in a while, or 50 milligrams a week, 25. I think at those doses, you don't really see blood pressure changes, but where most people start to notice the benefits, 150 milligrams per week, that's where the blood pressure starts to increase a little bit. So let's see, Trestolone, Anadrol, Winstrol, Boldenone, and then Halotestin. Can we put that in there?
Sure.
Yeah, and then the other ones I would feel are reasonably safe. And again, Halotestin is not something that you run long term. It's like a 2-week love experiment or love. If it's not 10 days. And then again, since you're at the end of prep, it's very unlikely, even though, again, on paper with the inhibition of cortisol metabolism and all these other side effects that Halotestin has, it's very unlikely that you see blood pressure increases because you're so goddamn lean. You're at the end of prep.
Yeah,
I've recommended Halotestin so many times to competitors, and I never see them have elevated blood pressure.
That's why I didn't think of it. That's why I asked about Halotestin.
Right.
It's not been an experience because I would only use it during prep.
Exactly. So if you use it at the end of an off season, for example, which
same with Winstrol, when we use
same with Winstrol,
at the end of a prep too. So
and then it doesn't really do anything to your blood pressure. Yeah.
So maybe if people stay leaner, it's possible if people stay leaner, they wouldn't have high blood pressure.
God damn it! But I like to eat, Kurt. I like to eat.
Then use more growth hormone.
Oh yeah, that's right. But then I get sleepy. use more stimulants.
Use it for
But that
longer
constricts
with
more
more
blood
stimulants.
vessels. That constricts more blood vessels. And then the last one we should discuss are the fat burners, right? Some of them increase your blood pressure a little bit. Clenbuterol seems to be a little bit
Depends.
person dependent.
Dose,
yeah,
probably.
dose dependent. For me, my blood pressure always went lower on clenbuterol, but again, I use it during cutting phase.
Yeah.
Prep.
Ephedrine will raise it.
Ephedrine, yohimbine at higher dosages,
Caffeine.
and then some of the nootropics like bromantane, Ritalin, modafinil, Adderall, if you consider that a nootropic.
Crystal meth.
Crystal meth. Yeah, crack cocaine. So from the ones that people generally use, I would say that it's only clenbuterol that really, and ephedrine that really cause elevated blood pressure. I think ephedrine more. That's why we got the ECA stack, right? That's why we got the ECA stack to kind of help, bring blood pressure down with the aspirin. And that's about it.
Yeah. Well, the aspirin's in there to prolong the half-life.
Yeah, but it also
probably
lowers
helps blood pressure too.
Yeah, lowers blood pressure also. And then out of all the other performance-enhancing drugs, I think it's mostly the steroids. The real good hardcore steroids that are fun to use that increase blood pressure. But from the entire slew of performance-enhancing drugs, peptides, melanotan too, maybe?
Is sort of, I guess.
Yeah.
But you get with melanotan too, if you go to, I wouldn't say like an extremely high dose, but let's say like 1 milligram of melanotan too, which you'd probably puke your guts up with.
Yeah.
The vasodilation effect that comes from that dose probably has blood pressure lowering effects.
Right. Yeah. Mm-hmm. I think that's about it, man. That you really have to be paying attention to. And then in most cases, the dose is the poison. The lack of the lifestyle and the dose is basically the sole determining factor
Pretty much.
if you need blood pressure medication or not. And I hate to say it, but taking these medications prophylactically the entire year.
No, Dean and I talk about that too. Not a good idea.
How about we do dieting cardio prophylactically the entire year? And with that, the Anabolic Roundtable is done before we really turn into a 0.5% audience retention. So next time we'll do the kidney tier list. What I had on there, maybe we can tease the audience a little bit. Hydration and electrolytes, yes. Blood pressure management, like we just discussed. And then there's actually not much you can do for your kidneys. You've got astragalus root extract and mitochondrial compounds like SS31 and SLUPP3. Maybe we should discuss that in 30 minutes. Do you guys have 30 minutes to discuss the kidney? Because it's actually not much.
I have a call.
You have a call? Okay, fuck
I
it
do
then.
have a call.
We'll do it next time.
Add it next time.
I think there's other things that we can add on, and we can do it offline, like glutathione, cordyceps mushroom. That I've got a whole host of things towards the kidneys. That kidney disease, what we'll circle back to, is oxidative stress and offsetting the impact
not
of.
Again, Dean.
Yeah, not again. With offsetting oxidative stress at the kidneys, and then lowering blood pressure so that you're not basically punching holes in your kidneys that will never repair themselves.
That was basically my conclusion of the bold and on deep dive regarding kidney health, oxidative stress, and lack of estrogen. And with that, we are done. Guys, the links are down below for these two beautiful gentlemen with a little bit of hair and a little bit more hair. Dean, your hairline looks immaculate, and Kurt, it's slowly coming back.
Slowly.
Slowly, good to see. Are you going to, like, once it really grows, are you going to do a hairstyle? Or
I don't know. Yeah, I'd like to have some hair again.
Okay. Yeah, I like it like this.
I like it like that too, but it's nice to have the option. So take better care of my hair.
GHK copper, bro. Look into that.
I've used it.
Oh, really? So you're on the peptide bandwagon? Okay.
I used that years ago, before it was
Really?
probably before it was popular. Yeah.
Oh.
There's compounded pharmacies that made it here for me.
Yeah. I'll do wonders for your hair.
Yeah.
GHK copper. It's and wonders for your nails. In combination with high dose growth hormone, you'll be cutting your nails and cutting your hair like twice a day.
Exactly.
It's like that scene from Indiana Jones, the Holy Grail. the Raiders of the Lost Ark, where he ages super fast and his hair grows super fast. You guys remember that? It's like around our time, right? Yeah, I remember that scene, right? Yeah. That's how fast it grows on GHK copper and growth hormone. But your skin looks youthful. So you get a youthful appearance, but your hair grows really fast. Too off topic. Guys, this was a pleasure. We'll see you next month. Let's give it 4 weeks. This will drop on Monday very fast because I have nothing else for my editor to do. And then let's see. Maybe the next episode on the Vigorous Steve YouTube channel is another Anabolic Roundtable. I got to get the daddy duty out of the way. Guys, I'll see you next month, okay?
Thank you.
Take it easy.
Bye-bye.
Take care.
Take care. Ciao.